Hello, I'm Asha Boisel, and today I'm talking to you about post-traumatic stress disorder. Some of the major diagnostic features from the DSM include actual exposure to a life-threatening death or serious injury or sexual violence. This is the most important one because the other symptoms like intrusive thoughts, avoidance, dissociative amnesia, and recklessness and irritability, that sort of thing, they can look like a lot of other disorders, but the main thing that makes it PTSD instead of something else is that there was actual exposure, either by directly experiencing it, witnessing it firsthand, or it happening to somebody that was very close to you, like a loved one or a family member. And that's what makes it PTSD over some other kind of diagnosis. And it has to be some sort of like natural disaster, abuse, assault, combat, or terrorism, that sort of thing. The body doesn't necessarily distinguish between regular stressors and traumatic ones, so you can experience a lot of the same symptoms in like an acute stress disorder or an adjustment disorder. But it's not post-traumatic stress disorder unless there was the life-threatening event that happened. But for most of this, trauma is held within the body, so you can experience physical symptoms even whenever there's not a threat currently happening. So the symptoms that a person experiences, the heart racing, stomach, falling out, and cold sweat, trouble breathing, that sort of thing, all the stuff that happens whenever in the panic of the moment will keep happening to a person every time they re-experience or remember their trauma. And long term, all those panic responses, which are helpful in the moment to help you survive, but long term, those can cause ulcers, asthma, insomnia, migraines, hypertension, heart disease, and a whole bunch of other kinds of disorders. It's pretty common, a pretty common disease. Some things that make people more likely to develop it than others is, as with most mental disorders, just genetics and poverty. If you have another mental illness, you're more likely to develop PTSD. If you experience a traumatic event, social support and the severity of the event also change how you experience the trauma. One of the statistics that I found was interesting was that some of the sources that I read said that women have a higher prevalence of PTSD, potentially due to socialization or temperament or something like that, but it's really just about an exposure risk. Like veterans and police and firefighters and EMTs and that sort of thing, women have a much higher risk of exposure to rape and sexual assault and domestic violence, abuse and that sort of thing, so they're obviously going to have a higher rate of PTSD. Dr. Vanderkolk wrote that book, The Body Keeps the Score, which is where a lot of my sources came from. He said social support is the most powerful protection against being overwhelmed by trauma. So even if a person is in a traumatic situation where they are likely to develop PTSD, if they have social support that's really there for them and is really going to help them experience it and process what's happening to them, then they're less likely to develop symptoms of PTSD. So dissociative amnesia, forgetting that the event even happened, and event distortion, which is where you misplace blame for what happened, are key symptoms of PTSD. And if a person doesn't remember that a trauma even happened, or that it was as bad as it was, all those other symptoms would mimic other things. Associated conditions with PTSD can have a lot of the same symptoms, but the key thing to remember is that they did not start or really have anything to do with a traumatic, life-threatening event. Adjustment disorders are pretty much exactly the same thing as PTSD, except that they're not from a traumatic event. Can happen with stressors of any severity, not necessarily life-threatening. Acute stress is exactly like PTSD, except it lasts for a much shorter amount of time. It's up to a month. Anything after a month can be considered PTSD. OCD has a lot of similar things, but they're not going to have like flashbacks and hallucination, flashbacks and that sort of thing. The intrusive thoughts are not related to trauma. They're related to perceived risk rather than actual things the person has experienced. Major depressive disorder, not related to trauma. The intrusive thoughts are not about a traumatic experience. Personality disorders can develop after a person experiences a traumatic event, but if it's just a personality disorder and not PTSD, then it won't have started right after something bad has happened, something life-threatening. Dissociative disorders are harder because dissociative disorders are their own thing, but you can also have a PTSD with dissociative symptoms. Then you can also have psychogenic, like blindness, paralysis, deafness, that sort of thing, where the blindness and paralysis, that sort of thing, will have developed after the traumatic event. Of course, a complete medical workup should be done to look for other causes of physical symptoms, but if there's not a cause for the physical symptoms that you can find on a medical workup, then there's no real harm in looking to see if there is some sort of trauma in the person's past that's going to cause them to have the physical symptoms. Psychotic disorders, the way that people describe hallucinations and the way that people describe flashbacks are completely different. A person with PTSD will say that the flashback, it's as though it were happening all over again. They experience it like it was happening. The voices in their head that are so overwhelming and so loud and so intrusive, they will acknowledge that they're their own thoughts. They're coming from inside their own head. It's not the same as visual or auditory hallucinations. And then traumatic brain injuries can happen as a result of trauma. A TBI doesn't have the re-experiencing and avoidance behaviors, but trouble concentrating and remembering can be due to a concussion or a brain injury. But just because it's PTSD doesn't mean that it's not something else too. 80% of people with PTSD are likely to meet criteria for at least one other mental disorder. But the good news is that the prognosis is good. Talk therapy is actually really helpful. We talked a lot about people who need to connect with each other in order to process their memories and be able to experience it in a way that's helpful, and talk therapy can do that. There was some evidence that group support therapy can be good at the beginning, but they tend to create an in-group, and anyone who doesn't have those bad symptoms and who's not really, really messed up from it can kind of become part of an out-group, and they can be less about healing together and more about reliving their trauma over and over again. Cognitive behavioral therapy is also not shown to be very effective against PTSD. Cognitive behavioral therapy has to do with, retraining the thought processes and reprocessing memories and stuff like that. But things like exposure therapy and that sort of stuff is not really going to be helpful for a person with PTSD because they know that it's not, it doesn't make sense, but it made sense at one point. It just doesn't make sense now. But they need help reprocessing the memory in order to be able to move past it. They don't necessarily just need to learn a new way to live. So cognitive behavioral therapy can help, but a lot of the most common ways of dealing with phobias and anxiety disorders that cognitive behavioral therapy doesn't really help with PTSD. Another thing that does really help is reconnecting the mind with the body. So if you have dissociative symptoms and numbness and feeling shut down, then your brain doesn't really connect with your body as much. People have decreased sensations, and there was a story in the book The Body Keeps the Score where the Dr. van der Kolk talked about putting a can opener or a set of keys in someone's hand and having them close their eyes and tell what it was, and they couldn't identify what they were holding in their hand, the difference between a can opener and a set of keys, because they were so disconnected from the sensations in their body. So meditation, doing yoga, that sort of thing. Meditation can be kind of triggering for people early in treatment just because it's pulling inside of yourself, and if the inside of a person is bad, it's scary, then it can kind of be a bad experience. One of the things that they have found to be really effective is called a butterfly hug, and basically you put your arms over here and you just alternate tapping on your shoulders while breathing gently. And I'm not really sure why that one helps, but the alternating back and forth has a tendency to help you reconnect your mind with your body. Medication for PTSD is often a good stopgap measure. Symptoms can be really, really intrusive and really mess with a person's life and ability to live. One of the things that I thought was the most helpful and interesting was patients who with PTSD who experience nightmares. There's not an SSRI isn't going to help with nightmares necessarily, and it may be too much to process a traumatic event, in one session or 2 sessions of therapy. And, if you think about it, 3 sessions of therapy is 3 weeks of life. And if you don't sleep for 3 weeks because you're having nightmares every night, that can be really problematic. So ACE inhibitors that are originally used to treat heart conditions have been shown to prevent or decrease distressing dream and intrusive thoughts. Has to do with just kind of slowing down that process. It'll slow down your heart rate, and slowing down the heart rate slows down the panic response that can happen. Some people with PTSD also take medications for depression and anxiety to help them while they're in treatment to overcome and process those memories. Another really, really interesting piece of science related to PTSD is eye movement desensitization and reprocessing. Basically how it works is you create a safe space in your mind, or the client would create a safe space in their mind and then move their eyes back and forth, alternating, or you can tap on alternating thighs or tap on alternating shoulders or something like that. Just create an alternating sensation. You can do it with sound or whatever. But you do that for a couple of seconds, and then the practitioner will ask the client how they're feeling, what they're thinking about, and you have they'll describe, oh, I was just thinking about my dad and how we used to play ball. Then they'll do the alternating again. What are you thinking about now? Like, actually, we only ever played ball whenever he was really mad at my mom. Like that sort of thing. It goes through the whole process, and they can process through traumas like that really quickly. The research that I read was that it was something like 80 to 100% of traumas were reprocessed in 3 sessions, which is kind of an outlandish claim, but they also have really, really excellent results. And it's just a cool bit of science. So the prognosis for people with PTSD is potentially good. You can postpone the symptoms until you're able to be in a place mentally to be able to process through those memories with some medication. Talk therapy and EMDR takes the heat out of those memories and allows you to process them without holding on to the emotions. And connecting your mind and body increases resilience so that in the future, if you experience another traumatic event, you're less likely to develop PTSD. Unfortunately, therapy requires money and transportation and health insurance. So it's not offered to everyone. It's not available to everyone. And done poorly, these kinds of therapy can also lead to re-traumatization. If a person doesn't feel safe and comfortable in the therapeutic relationship and in their therapeutic environment, then they can really be hurt by that. By re-experiencing it even in a controlled environment, because the environment is not under their control, it's under somebody else's, and so they can feel re-victimized over and over again. And you also have to have a person who is willing to face that trauma in order to be able to process it. And because one of the main symptoms of PTSD is avoidance of triggers, it can be hard to fortify against that and to really convince a person to be able to process through their things. So it's mostly good news if you can get people access to the treatment. The treatment is actually really effective.